Hi, thank you for tuning in. Welcome to the It's Your Money and It's Your Estate workshop series brought to you by our nonprofit organization, Financial and Estate Literacy. Our mission is to empower people like you to take control of their finances, their estate, and charitable giving decisions. For the past 25 years, our founder, Peter Kote, and our entire team have been providing these free, unbiased, and accessible 6 weeks programs all over Orange County, California to help you make informed choices that align with your unique needs and values. Now let's start the program. This webinar is the third session of the It's Your Money program. The topic is medical care planning. Our moderator is Peter Kote, and this webinar is brought to you by Laguna Beach Seniors at the Suzy Q. Enjoy the workshop.
So many a times when I serve as an agent for people's healthcare in their advanced healthcare directive, I don't know what the seriousness of the injury or what needs to happen. For example, I had an individual who was brain injured. Well, needless to say, I don't know much about brain injury. And so I hired a care manager, and she was absolutely wonderful. She assisted me in figuring out what was the best level of care for my client. And this is a fairly new profession. Like it says, it comes from diverse qualifications, education, and experience. A lot of retired registered nurses, RNs, become care managers. Individuals that have been doing social work sometimes become care managers. But they know more about the medical field than certainly I. And so and it's great for me to be able to talk to them to figure out what is the best course. These care managers are available to you as well. Now, who needs to know this stuff? Well, you do in a little bit of a way, but your agent under your healthcare document needs to know that care managers are available. If you go to the next slide, this is a little bit what they do, but every one of us needs an advocate. If we can't speak for ourselves, or we're a little forgetful, or we don't want to. We need somebody, especially if we're in an HMO. But even straight under Medicare, we need an advocate. Sometimes it's just, somebody in the family who keeps the conflicts under control, somebody who understands and advocates for you in the health system. And monitoring is just so important. Let's go to the next slide. This is a really important slide. This is one of the things that you have named under your advanced healthcare directive. You have named an agent. That agent, a lot of times, is going to be your spouse. It could be one of your family members, or could be a professional, or could be a friend. I probably wouldn't do it to a friend, but you can find individuals on this association, and they charge anywhere between $100 to $175 an hour, but you don't need them, on 24/7. You need these individuals to sometimes help you with prescription drugs, sometimes with a diagnosis and what care facility is the best for your medical situation. Uh, 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 Insurance is not easy. Some of them can help you through that whole insurance process. So, but your agent under your advanced health care needs to know this resource. Let's go to the next slide. You think money has its own language. Well, the medical industry has its own language as well. And so when you're in the hospital, it's because you need acute care. I think around 20 years ago, you could go in the hospital because your stomach ached or for lots of different reasons. But today, you're only admitted if you need acute care. That's the phrase. Um, um, when you're Eugene, you were recently in the hospital.
Yes.
When you were in the hospital, how soon did you meet with the discharge nurse?
Right away. They wanted me out of there. They said,
Yeah.
"Hey, are you feeling okay? If so, get out."
Yeah. One of the first things you do is meet the discharge nurse,
Yeah.
and um, you're not in the hospital very long unless you absolutely need to be there, which is a good thing. But let's say if you were strictly under Medicare, not an HMO, and you were strictly under Medicare, well, Medicare pays for hospital care. But once you come out of the hospital, you may need skilled care. And what is that? Rehabilitation. Well, Medicare pays for skilled care for 20 days full cost. But you have had to be in the hospital 3 days plus one. So essentially 4 days. So if you're there 2 days and you don't feel ready to be discharged, you may want to talk to the nurse or to your hospitalist.
Why do they call it 3 days plus one? Is there a reason for that?
Yeah, I don't know why. I think it's that you were seriously ill.
Oh, okay.
Because Medicare pays for it, and skilled care costs somewhere between $180 to $250 a day.
I see.
So it's quite expensive.
Yeah.
Um, um, uh, so, um, but here again, when you go into the hospital, you don't have your primary care physician with you. They're not in charge. So the hospitalist, the medical doctor that's in charge of you, needs to hear from your agent under your health care. They need to know what prescription drugs you're on. If you can't communicate, they need to know if you're allergic to any kind of a drug or any kind of a procedure. Some people are, allergic to latex and that's pretty common in hospitals.
Yeah.
So when you go into the hospital needing acute care, you don't have you're not on top of everything. You may be on drugs, you may have just had a procedure. So you need an advocate, and that advocate should be your agent under your health care. Once you're in the once you enter into the skilled care facility, then you have 20 days that Medicare pays for it. If you're under an HMO or an Advantage plan, you have to read the contract, but it's fairly similar, but it could be a little bit different. So you may want to take a look at that or call your HMO if you're there. So what I have, when I've had patients or clients in skilled care, what I have often heard is, gosh, your mom, they always think it's my mother or my father. It says they're 90 plus years old and we don't see much of an improvement.
Mm.
And we're going to discharge them from the skilled care facility. Well, again, improvement is not, lack of improvement is not a determinative factor. It's to get the care that you need. If you have a hip injury, you need to walk every day. It's when you're 90 years old, maybe a little overweight, maybe you have a little bit of a dementia or cognitive decline. You rather lay in bed than get up and walk. But getting up and walk is what's good for you. So you need an advocate there. And the medical person who's in charge of you is the medical director for the skilled care facility. So you need to understand that as well. Once you're out of once you're out of skilled care, then you have custodial care. And all the language under custodial care is about activities of daily life, ADLs, they call it. And we'll go through what those are in just a little bit. And you can have custodial care at home, or you can have custodial care in an assisted care facility. I think I don't hear too many people using the term nursing home any longer, but
Mm.
it's on the slide. If you go to the next slide, please. So Medicare pays under Medicare, it pays for the skilled care, but not for custodial care. And we'll get into the ADLs in just a little bit. Medicare is a little bit complex. Johnson administration started it. I think it's awesome that we have this. Part A is hospital. Part B is medical services. Part C is private insurance companies with that have certain extra benefits. And then there's the prescription drug program. The hospital insurance covers inpatient hospital care, hospice, skilled nursing, and home health. And then the medical insurance covers outpatients, doctor visits, preventive services, ambulance services, and the like. Let's go to the next slide. This is another slide that your agent for your advanced healthcare needs to know about. If you have long-term care insurance, it's so difficult to understand. And yeah, you purchased it, you paid a lot of money for it. So if you have a question, HICAP is just great. It's located right here in Orange County, and they'll help you understand that long-term care contract. They'll also have all sorts of information on Medicare, what it is. We're coming up to that you can change your Medicare provider, and that comes up every October. I'm not sure of actually the dates. I'm looking up my other screen to see when but it's October. It's coming up in this month. If anyone knows, put it into Q&A as to what those dates are.
Are you talking about the enrollment period?
Here it is. Yeah, enrollment period is October 15th
to
to
December 7th.
December 7th.
Yep.
Big. This is the time that that you can make changes. And if you're born if you've been on Medicare prior to 2020, you have a lot more options than if you have started Medicare after 2020. Again, we can't go into complete detail, but just know that you have more resources open to you if you've been in the program since 2020. There's a lot of controversy whether or not you want strict Medicare and a Medigap policy. There's been some changes in Medicare. There's there's no longer the what they used to call the donut hole. That's going to change in 2025. And if you don't know what the donut hole is, don't worry about it, because you weren't involved. And in 2025, it's going to go away, which is a good thing. Let's see. What else would you want to know? Going with straight Medicare and a Medigap policy and going with an HMO or an Advantage plan is a real personal discussion. We were personally in our family, we were in a HMO until my wife got cancer and she needed a lot of cancer treatments. And so during the October period, we switched over to Medicare and Medigap. So that worked out well for us. But it's an individual decision, and need to understand what the ramifications are. Let's go to the next slide. This is huge, long-term care. Some of us, the statistics are all over the board, and some of them are a little bit high. But it's life is a circle, and we start off needing help and we end up needing help, and that's just the way life is. And so they call it long-term care, and they talk about it with activities of daily living. Can you bathe yourself? Can you dress yourself? Can you toilet yourself? Are you suffering from continence? Can you ambulate? Can you feed yourself? It seems that these are all normal activities, and they are. But at some point in our life, we may have problems with this. My father had rheumatoid arthritis, and so he had an enormous difficult time dressing and bathing. So at the time, traditionally, my mother took care of him. And the statistics are that most women end up being the caregiver. And the another sad statistic is that many caregivers, or women or men for women, but women are the most, die before the person that they're caring for. It's helping somebody do bathe, dress, toilet, continence, transfer, and eating is an enormously difficult job. And so, but we need to think about it as to who's going to be there to take care of us, to help us with this activity. One alternative, insurance, and we'll talk a little bit about that, but that's dwindling because of the cost of the premiums during our lifetime.
Yeah.
But this language is used by insurance companies to kick in your long-term care insurance if you have it. It's used by skilled nursing facilities. It's used by hospitals. People in the medical field use these terms, ADLs. And most insurance companies require you to have a problem in at least 2 to 3 different areas before the policy will kick in. They'll even send a registered nurse to your home and interview you and to see, are you bathing yourself? Are you dressing yourself? Now, most males, when they have the RN come in, they want to show that they can dress themselves. But this is not the time that you want the person to do well, especially if you have an insurance policy. So cognition, dementia is in here as well, but it's usually not listed as an activity of daily living. Let's go to the next slide. Yeah, who's going to pay for it? Big one. I like to call this a 2-step process, a 2-step dance. What I see most individuals do is immediately purchase long-term care insurance if that's available, or immediately talk to a reverse mortgage individual to pay for long-term care. What I vote on and what you should look at is, can you self-insure? What is your net worth? It's all the things that we were talking about in Financial Planning 1. Do you understand your net worth? Do you understand your cash flow? Do you understand the cost of what's going to happen? Before you go and look at a reverse mortgage or a long-term care policy, you may be able to to buy down as far as your home is concerned. You may be able to take out a hard money loan on your house if you want to stay in your house. You may have a family member that can step up and assist you. But most of us are going to die before we need long-term care assistance. And if we do, it's usually, if we're 85 plus, it's usually 3 months or less. There's huge amount of fear involved in here. And we want to stay as independent as possible for as long as possible. So, but it needs to be discussed. I mentioned to my mother that she could live with me when she got older. And she said, there's no way that I'm going to live with you. So, but it needs to be discussed. And she ended up living with my older sister, which of course was much better. And she had a bigger house and they had a place where she could be independent. And that's always a key. We could transfer the cost to insurance, but literally there's almost one insurance company today that's offering long-term care insurance. So it's really gone down. Government benefits, Medi-Cal here in California, it's there. We'll talk about it a little bit. It's no longer asset driven, it's income driven. And we'll talk a little bit about that later. Veterans benefits are there. They're awesome. It's available. Possibly you have a life insurance policy that you can sell. And at last, luckily, there is a reverse mortgage that's possible. Just don't put reverse mortgage on the top of the list. Look at other things first. And not all reverse mortgages are alike. If you see them on a commercial, they're probably not the best for you. Somebody has to pay for that commercial. and reverse mortgage companies, you're buying debt, and the last thing you want as you get older is debt, and it's very expensive. But luckily it's there. It's what I consider to be the last option that you look at. Let's go to the next slide. Yeah, we're not going to spend too much on this, but if you have a policy, make sure that you keep the policy with your estate planning documents.
What is this most likely will be required in California? Is there a pending litigation to it's almost like health insurance where
In California, they're talking about having that each one of us will be required to have long-term care and pay for it like we do
with
Medicare.
health insurance. I see.
Yeah, health insurance.
Okay.
It's the cost is so high.
Yeah.
To hire a caregiver, for example, today, if you need somebody 24/7, it's in the $15,000 to $20,000 per month.
Yeah. Yeah.
So, who can afford that? And if you hire a caregiver, they're subject to all the employee rules.
Right.
So after 8 hours, you got to give the caregiver time and a half.
Right.
Holidays, time and a half.
Yep.
So it's really it's difficult.
Yeah.
And there's a lot of agencies out there that you can hire caregivers through, and they'll take care of the payroll and everything else and the insurance. But again, that's at a higher cost.
Right.
So, and there's only so many caregivers to go around. And here in Orange County, we have a wonderful climate, and hospitals are fantastic. And so we have a large aging population here. So, and long-term care insurance pays for assisted care as well. It pays for memory care. So, but it's just so expensive. And so what happens a lot of times is that individuals drop paying or drop the policy because the premiums are increasing. And the thing of it is that in these policies, it states, hey, your premiums will not increase.
Right.
So how do they do it? Well, they go up to the insurance commissioner, and the insurance commissioner is faced with a dilemma. Either we allow the insurance company to increase their rates, or they're going to stop providing the policy. So, a lot of times these insurance policy increase their premiums on an annual basis, and that can run anywhere from $5,000 to $10,000 per year. So it's pretty expensive. You need to understand the type of policy that you have if you have long-term care. And these are what's called indemnity policies. They pay on a per hour basis. So you can get coverage for $50 an hour, and you can get coverage for $500 an hour. Again, if you get it for $50 an hour, your premiums are going to be quite low. If you pay for $500 an hour, your premiums are going to be substantially more. Some policies have inflation protection. If you have one of those, you're paying a higher premium. Some of them are, well, I would say if you do, the only kind of policy to have is a comprehensive policy. So you could be taken care of at home, or home care, respite care. I've had an individual that only had a nursing home care or assisted care. The last thing he wanted to do was move from his home, so he never turned to the policy. Avoid specific disease policies. Quack, quack, that duck, Aflac.
Oh, Affleck.
Please avoid them. If you like the company and the duck, become a stockholder. Okay. You have to die from that specific disease in order for that policy to pay out. Who knows how we're going to die or what the final doctor is going to state on the death certificate. And these things are they're oversold. Determine the financial health of the insurance company. Well, how do you do that? Each insurance company is rated by Moody's, by Standard and Poor, gives you some indication on the financial health. The long-term care is a fairly young insurance policy, and they didn't have a lot of history, the actuarials. And the oddball person could rack up enormous cost. In other words, you could be in an auto accident and be unconscious, and they can keep you alive for 20 to 30 years. And that cost would be paid for by your long-term care policy. Well, that cost would be enormous. And so most insurance companies have gone out of the long-term care business. So, but if you do have a policy, please understand it. Your agent needs to understand it. And the best place to go is HICAP, the Council on Aging, the slide that we had shown previously. Let's go to the next slide. This is no longer in existence, so let's go to the next slide. How premiums are determined. Again, this is really important if you have a long-term care policy. Elimination period means is when does the policy begin paying? So if you have a 90-day elimination period, the first 90 days, you have to pay yourself. Okay. Once you paid that first 90 days, then the policy kicks in. Some policies have 6 months. Some have 1 year. Your premiums are going to go way down depending on the elimination period you pick. So also the age and the disbursement amount, $50 to $500 a day. The length of coverage. CalPERS used to offer lifetime policies. They have now switched over, and the maximum that they will provide is for 3 years. And by the way, 3 years is a good maximum type policy. Lifetime is just way too expensive. Let's go to the next slide.
By the way, we're almost coming on the halfway mark, and we're on slide 13, so about a third of the way.
Yeah. Okay. Medi-Cal, thank you, Eugene. I appreciate that. Medi-Cal, it's available for individuals. I would recommend highly that you see what's called an elder care attorney to help you through this process. And it's changing. As of January 24th, As I said before, they're not looking at assets for approval, but they're looking at income. At the time of your death, they'll look at your assets. It's a great program. There are some scammers out there
Oh
that
yeah.
quote unquote will try to get you qualified. You know, try to, again, if you're in this particular situation, needing Medi-Cal, or let's say you have your net worth besides your house has gone down immensely. You have $100,000 left as your manageable assets. This is the time to begin exploring and going to an elder law attorney and seeing about what government programs are out there to assist you. And luckily we have these. And how do you find an elder care attorney? There's an organization called the Academy of Elder Law Attorneys that I highly recommend. And if I was looking for an attorney for an older individual in another state or another county or in Northern California, I go to the Academy of Elder Law Attorneys and put in the zip code of the clients, and I ask them to look around that area for that kind of advice. It's its own specialty today. Let's go to the next slide. Skilled nursing facilities there are a few that will take you for the long-term care. There's about 6,000 plus what they call assisted living arrangements. That's a home in your neighborhood that's turned into somebody's turned into a care facility, and you can also get in-home care, of course, through caregiving services and the like. By the way, again, here, again, your advocate, your agent for your health care needs to know about this, because even if you looked around today and said, oh, this is the home I want to be in. Well, you don't need the care today, but you may need it in 10 years. And in 10 years, it could be a completely different situation. So a lot of times it's a good idea to ask us as professional fiduciaries, or to ask ombudsmen are absolutely terrific, as to recommendations. But if I'm hoping where you're getting a sense that whoever you named as your advanced health, as your agent for your advanced health care, they've got some work to do. There's time involved. They can't just, hey, show up one day and say, okay, I'll talk to your doctor for 20 minutes and make a decision for you. This is an ongoing process. And so if you're going to name an agent, make sure that they're local, make sure that they can communicate, make sure that their religious beliefs match yours, make sure that they can do what you want, not what they want. This is all about you. Let's go to the next slide. I love help. Helped us with the Ask First form. That's where we get this form from. It was started by an attorney in Long Beach who got fed up with the dying business. By the way, the dying business is huge, because all of us are going to go through it.
Right.
We don't have a choice. And so, and we're in an entrepreneurial capitalistic system. And so there's from insurance policies, health care, doctors, attorneys, us fiduciaries, funeral homes. It goes on. Death is a big business. This particular website is awesome. They print a booklet called Your Way. And when we meet with a client and they ask us to be the healthcare agent, we go through that Your Way booklet and spend about an hour talking about what you want, how you want it. Do you understand hospice? Who do you want us to call? Who do you not want us to call? What kind of quality of life do you want? How do you feel about morphine? How do you feel about pain? The booklet is free and it's available through help. Let's go to the next slide. Advanced care planning. Well, you got to talk. What kind of quality of life? Dr. Kuntz, who was he's a medical doctor at Saddleback Hospital, and I was listening to one of his lectures, and he was 85 at the time, and he says, if I can't ride my bike every day, life is not worth living. That's him. Now, for me, if I can't control my remote control, maybe that's the end. But you need to talk about this. Conversation with loved ones, identifying loved ones who can make decisions. I have 3 sisters, and one of my sisters would never want to be involved in this. You got to make sure that all the paperwork is done. And we'll talk a little bit more about that. And medical, it's not stagnant, If you have Parkinson's disease, some people have Parkinson's disease, that disease doesn't progress. Others, I've seen it progress so far in less than 5 years that it's just amazing. So, and it's so hard to be realistic, about medical issues. And we're not living in a society where medical issues are freely discussed. And I've had situations within families where the grandkids were shut away. You don't want to see grandma or grandpa in this particular condition. And I find that abhorrent. We're all going to go through it, and they need to learn and understand our life cycle. Let's go to the next slide. The POLST is what's called a physician's order for life-sustaining treatment. And this document is pink. And the reason why it's pink, so it stands out from all the other medical documents or medical records that you get. The Advanced Healthcare Directive is #1 document that you need completed, and usually that is completed when you do your estate plan. I recommend highly on the Advanced Healthcare Directive that you, especially here in California, that you complete the California Medical Association one. You can get it online, and you can order it by phone or by online, but it's the California Medical Association. The reason why I recommend that one is that most hospitals and doctors and nurses understand it, are familiar with it, etc. They may not be familiar with your individual attorney's document, But the most important thing about that document is that it gives another person legal authority to make medical decisions for you in the event that you cannot make them or communicate them yourself. The doctor is going to listen to you first. But maybe after you come out of an operation and you're fully drugged and the decision has to be made, you can't communicate with the doctor. That's when your agent kind of steps in. Okay. Now, the pulse is something that I usually recommend for people who believe or have gotten a diagnosis that they have a short period of time to live, 6 months to a year, and then have that conversation with your primary care physician and say, I want a doctor's order to tell me what you want at the end of your life. And that's what that pulse is about. Doctor's orders are God in a hospital or in a medical center. So that's why that pulse is important. There are many individuals who are on ventilators for a long period of time because either they don't have a pulse or they don't have an advanced healthcare directive, and the state of California will never pull the plug. Okay. They're just won't do it. And so there are people out there that have been on ventilators for 10 or more years because totally unconscious, but still have a heartbeat. That's another thing too that you want to have a conversation about. Are you dead when your brainwaves stop, or are you dead when your heart stops? The law says when your heart stops. For me, if I don't have any brainwaves, they shoot horses, don't they? I don't want anybody to do any extraordinary means to keep me alive if I don't have a brain left. But each one of us is a little bit different, and there's how you feel is up to you. There's no one else that should convince you otherwise. Let's go to the next slide. Here's the difference between the Advanced Healthcare Directive and the pulse. Anyone 18 and older, if you've got, a kid that's going off to school and he's 19 or she's 19, you're no longer in charge of their healthcare. They need an Advanced Healthcare Directive. Pulse, if you're seriously ill or frail at any age, but I usually make it, if you've got a year or less of life, then a pulse is something to look at. Advanced gives general instructions about future treatment. There's one of the articles in that's available online talks about future. None of us know how we're going to act at the time. I've had individuals that have sworn to me that I want you to pull the plug immediately, and if there's anything wrong. The time comes and the doctor asked them, would you like to, what do you want me to do? And they choose, I want to prolong my life. Okay. So allow yourself the right to change your mind. The pulse talks about specific orders for current treatment, cancer. I don't want any more chemo. I don't want any more radiation. For some people, the treatment is worse than dying.
Yeah.
So, it's tough choices.
Yeah.
The Advanced Healthcare names a person who's making those decisions for you. Under Pulse, your decision maker can sign it. So if I'm a healthcare agent for someone and I believe that a Pulse is necessary, I can sign that document on behalf of my client. Let's go to the next slide. How are we doing on time?
Top of the hour. So
Top
30
of
more
the hour.
minutes.
So we got about 30 minutes left?
Yes.
Okay. Yeah, studies showed only about 25% of Americans have reported their medical care wishes in a legal document. Um, yeah, my mother, perfect example. She goes, if you bring up death one more time, that's it. I'm going to disown you.
Oh, no.
Nobody likes to talk about it, you
Yeah.
know, but Thanksgiving is coming up. It's a great
Oh.
opportunity. Turkey is dead. Hey, we will be too at one time. But yeah, you got to talk about it. The book Tuesdays with Maury, if he talks about the process of dying. I love that book. Just have a whole carton of facial tissue next to you
Mm.
as you read it. But it's excellent. Um, um, Most people think that it involves an attorney. It doesn't. That's why you can get a California Medical Association one. And if you want to update it, get another California Medical Association one. They're available online. Every hospital will provide one free to you. The Council on Aging will provide one that's free to you. These documents that you do today don't go out of date. The problem, though, is that you want to be able to make sure that the medical staff or the doctor that's treating you believes what your agent is telling you. In other words, if you haven't talked to the agent and your document is 10 years old, well, that physician is going to say, yeah, when's the last time you talked to your mom or dad or whomever you represent?
Mm.
The documents get stale, and you want this to be up to speed, and make sure you include the prescription drugs that you're on. Make sure you include if you're allergic to any drugs. Make sure you include who your primary physician is. Make sure you include if you have any specialists in that document. And then make sure that your agent for your health care has a copy of that in their glove compartment. Make sure you have a copy and put it in your glove compartment. This is not a document that you keep secret. Let's go to the next slide. My plan, well, 50% not able to make their own medical decisions, because usually, it's an emergency situation. And so, and the default is to treat you aggressively, which is a good thing, at 90% of our lives. But if I'm 100 years old or if I'm 95 and I've had two or three issues already, do I really want a 30-year-old to pump my chest and break my bones or to do aggressive procedures to keep me going? If you're asking me today, I would say no. I don't know exactly what I would say if I was 95. Uh, um, and it's almost impossible to predict what a family member would want. You've got
Yeah.
to verbally, in writing, state it. Let's go to the next slide. This is what the pulse looks like, and you can download the form from these sites. Let's go to the next slide.
Oh. Yeah.
I like that. Hope is
Yeah.
not a plan. I used to think that as we get old, I've been doing this workshop for 25 years. And, when I first started, I thought, as you get older, everything gets easier. Ha! Wrong.
Mm.
As you get older, everything gets more difficult. I got more aches, I got more pains, I got there's all sorts of other issues
Yeah, we
involved.
don't want to hear that, Pete.
No,
Come on.
let's go to the next slide. Here are the books that are or pamphlets that can help you. There's conversations started. There's 5 wishes. Um, uh, uh, there are tools out there that you can get along with your agent for your health care. They need to be involved with you to have this conversation. Let's go to the next slide. I love this booklet.
There we go.
This is the Your Way booklet that we were talking about from Help. It helps you think about what is important. It kind of talks about hospice care and palliative care. Because, and I love the title. This is your way. It's your life. And so my mom and dad never talked to each other about wanting what kind of medical care did they want at the end of their life, So, and maybe the spouse isn't the best person to make decisions for you because it's quite emotional.
Yeah.
So anyway, I highly suggest that you keep this Your Way booklet with your documents. It is not a legal document. Okay, this is not an advanced healthcare. This talks about your feelings. Where this comes really into play is that the agent that you have chosen, whether it's your spouse, whether it's a family member, kind of understands and knows what you want and can communicate that to the doctor. I've even showed a medical doctor the booklet and say, we went through this booklet and I understand and what she wants. And once the doctor believes that you know the patient, they're more readily to listen to the agent because finally the doctor's orders are what controls. Let's go to the next slide. I think we beat that one to death.
Yeah.
No pun intended.
Well,
so if you live in another state or vacation in another state, I highly recommend that you get an advanced healthcare directive for that particular state. So and you yeah you just want to be able to. It's all about legal authority, so to make medical decisions. Let's go to the next slide. Who do I choose as my agent? Eugene serves as an agent in other people's healthcare documents. So do I as a professional. But most individuals choose their spouse first. Sometimes people choose a friend. I find that sometimes to be an issue. Sometimes a person in the family, but what you don't want is a co-situation. Now you've created a possibility of a disagreement because now they have to agree totally on the decision. Name at least 3 people in your document. I would name somebody who was close by, geographically. I would not depend on faxes and iPads and Zoom and telephone conversations. You need to be there. It's too important, and people will tell you everything is fine too easily over the phone. You have to see it for yourself. Let's go to the next slide.
When you say 2 or 3 people, you mean successors, not co.
No, in succession.
Yes. Yeah.
What makes it legal? Your signature and a date. The 2 witnesses just have to see the signature. So, or you can have it notarized. if you're in a nursing home or in a skilled nursing facility, you have to have the ombudsman there. So, which is important. For example, I have a situation now where I'm a co-trustee with a client, and she is getting dementia, but she wants to stay in control. I can't do anything as a co because we need her signature on things. And so I can't speak to the doctor unless I have the advanced healthcare directive. So even, these documents kind of mesh together. So I can, if I get the doctor to indicate that she lacks capacity, then I can act as a sole trustee and we can start paying bills and start doing things. Let's
Yeah.
go to the next slide.
And just to clarify, an attorney may even put in there each individual can act independently, but even then, it's hard to deal with because the banks still want to see, even though it says on there legally, the banks still want both individuals to come in, and
Yeah.
it makes it very difficult.
Yeah. Yeah, what types of instructions, where you would like to die, your medical doctor preference. Remember, your primary care physician is not going to be the person in charge of when you're in a hospital and will not be in charge of you when you are in a care facility, so a skilled care facility. It's also a little bit of a conflict. Some medical doctors do not do hospice care. And so what happens is that, let's say you're in an HMO and they don't do hospice, then Medicare pays for hospice care, but they would lose that payment if you went on hospice. So, what I find is that people wait way too long before they get on hospice care. And you can get off hospice care the next day if you're on it. So it's not you got choices. But what I find is that people under 50 years old, when they hear the word hospice, they go, okay, that person is dying.
Right.
No,
Condemned.
it just means that according to a medical physician, that you have a 50% or greater chance of dying in the next 6 months. Jimmy Carter, he's lived now under hospice for over a year. 20% of all hospice patients live 2 or more years. But what it means is that the pressure is off. You don't have to get better if you don't want. We're not going to do curative care. We're going to do comfort care. We're going to bring RNs and check on you. We're going to bring somebody in to help you bathe. We're going to have a chaplain there if you want it. All paid for by Medicare. It's an awesome program. Hospice programs have really proliferated here in Orange County. So depending on, you now have to pick the hospice care organization with a little bit more care than maybe 10 years ago. Let's go. Quality of life is so important. If the Dr. Kuntz likes to ride his bike, well, if he had a major stroke and he was paralyzed, he might not be able to. So I usually ask, what do you want me to do under these circumstances? Organ tissue donation. If you're past 70, very few organs or tissues are valuable, but your whole body may be valuable to medical school. So, UCI, UCLA, they'll take your body, they'll take and they'll pay for everything. So that's a choice. Next slide. What do I do when I have completed my investment? This is not something to keep secret. Okay, give a copy to your decision maker, your agent. Keep one in your glove compartment. Give one to your primary care physician. Photocopies are just as valid as the original. If you move in a hospital from one floor to the next, a lot of times you'll get a whole new staff and they won't know. And a lot of times your advanced healthcare director doesn't go with it. So tell your agent when they visit you in the hospital and you have moved, take that advanced healthcare directive with you. Let's go to the next slide. Where do you keep it? My completed pulse, same thing. Make sure your agents have a copy of it. And again, this is another good reason why you don't want to name an agent from out of state. Can you imagine they get a call, they're in, let's say they're living in Vegas. They get a call and saying, okay, you need to come here. Well, I mean, you're hard pressed putting a bag together with all your clothes, much less remembering, okay, I got to bring the pulse. I got to bring my advanced healthcare directive, blah, blah, blah. Find somebody local. And professional fiduciaries can serve in that capacity as well. Let's go to the next slide.
Oops, sorry.
We talked about the pulse. A pulse is not a DNR. DNRs do not resuscitate. And you never want to do a DNR, I personally believe anyway, in advance. You're on your third operation for cancer and you go, I don't want anything more. I'm 90 years old. Okay, maybe now a DNR is in order. I would say the pulse is 1 year to live. A DNR is 3 months or less. Let's go to the next slide. Well, more about the pulse. I think it's understandable. Let's go to the next. Yeah, this is kind of important. If you don't have an advanced healthcare directive, then usually the physician or the medical team will make that decision for you. And there is, here in Orange County, it's not an issue about keeping you alive. I mean, we have the best medical facilities, the best, latest equipment. I mean, we are up at the top. For me here, what the issue is that how long do you want this treatment? Here, it's about quality of life. Going through radiation treatments is not a walk in the park. Having surgeries, when a surgeon says this was successful, it means you're alive at the end of the surgery. It doesn't talk about the quality of life 2 years later, so you got to think about this stuff and who you name. It's sometimes who's most available, the most vocal, I don't know, person who visits the most often, just someone who understands, who's not a wallflower, who can communicate with medical staff. Let's go to the next slide. Oh, by the way, if I forgot the whole point of that slide. The point of that slide is if you need a medical decision made and that the physician disagrees, you'd have to go to court. And you would have to get a conservator appointed, and that called conservator of the person. And then that conservator of the person can make medical decisions for you. But it'll take at least 6 months. It'll take a $10,000 to $20,000, and it is a hassle. You can pick up an advanced healthcare directive for absolutely practically no cost, or $10 through the California Medical Association one, and they can make decisions for you. So there should be no excuse for any of us not to have an advanced healthcare directive, except for procrastination. We all procrastinate. Let's go to the next slide. This talks a little bit about, at 18, every one of us should have an advanced healthcare directive. We should update it periodically. When we get a serious illness and we go through some of the medical process, we need to take a look at that advanced healthcare directive again and have that conversation. Now that you've experienced it, what do you want us to do? Give you more morphine and may hasten your death. Some decisions to be made. Yes, next slide. Palliative care versus hospice care. Hospice with younger people and some older individuals has gotten a bad rap, i.e., you're going to die. So they've created another category called palliative care. It's hospice care means no curative procedures, but you can get off of hospice care and get a curative procedure. I don't know why. Palliative care is sometimes more palatable to the family and to the person, because under palliative care, you can get both curative and comfort care. So there's organizations, and we have an article talking about the difference. But again, who needs to know this? Whomever is your agent for your health care. Because if you're needing this, you're not going to be in the best of mental conditions to make a decision. So you need to talk about it beforehand. Thanksgiving Day dinner. Let's go to the next slide. This is Marcella's contact information, and here's some great resources that you can go to. Being Mortal, if you haven't heard of that, it's a medical doctor who took care of his father, and he found it unbelievable how many medical doctors could not talk about death, did not know about how to treat somebody who was in the dying process. So I think we're back in the 1950s as far as death is concerned. We're getting a little better. I compared to birthing, where back in the 50s and the 60s, the woman had to do it all by herself, and it was between her and the doctor, and her family was not involved. It's kind of, we're getting a little better as far as dying is concerned. To me, dying is a family process, and you want your loved ones there. That's it.